So I'm Professor Francene Steinberg, professor in the Department of Nutrition at UC Davis, department chair. I also have a background as a registered dietitian, and so I practiced as a dietitian for a while before I came back to school, and now my focus is on dietetics education as well as research on food and dietary interventions to decrease chronic disease risk, with particular emphasis on cardiovascular disease and dietary food bioactives. But to understand the effect of some of these food and nutrition interventions on chronic disease, it's really important to understand some of the biologic underpinnings of why disease occurs. We've heard a little bit about nutrition transitions and the influence of disease causality, looking at effects over a lifespan, and so I'd like to talk a little bit more specifically about the effects of overnutrition or overweight and obesity on chronic disease risk. So that's the topic for this presentation, and the objectives are to be able to give some examples of obesity-related disease comorbidities, and to understand some of the biologic mechanisms behind those development of comorbidities. One of which is just understanding some of the basic biologic functions of adipocytes, or the fat cells, and then to be able to describe some key points about why visceral or central adiposity can have a risk of chronic disease, and what some of those influences are on that visceral adiposity and adipocyte dysfunction. And then finally discuss the significance of some of these factors in terms of the metabolic health for both children and adults. So you saw some of the earlier graphs looking at the distribution of obesity, and so this is the last one that Dr. Stewart showed, looking at some of the high levels of risk of obesity. This is the very latest data from Centers for Disease Control. It just came out this August, but it reflects back in time 2010. And so the highest risk is greater than 30%, and then the lighter orange is 25 to 29%. And this is the percent of the population in these states that have a BMI greater than 30. And that BMI, or body mass index, is what is classified for obesity of greater than 30. So you can see that the central part and the south, definitely high risk. California in the west, still pretty darn high, in the range of 20 to 24%. So that's indicating that about a quarter of our population in this state is considered clinically as obese. But what's even more disturbing is to look at trends in the young. And so this other graph on this side is the 2011 State Prevalence of Obesity among very young children. So these are preschool children, aged 2 to 4 years, and particularly focusing on low-income populations. Low-income populations tend to be those of greater diversity, not exclusively certainly, but can be. But look at this. It's in the very highest, one of the highest ranges. So, greater than 20% of our population in this state, of some of our youngest children, are already considered obese. So that's a huge warning, red flag, wake-up call. What does this sort of preview for the state of our adults as these children get older? What does it mean, not just to a statistic, obesity or not obesity, but what does this mean for chronic disease risk, for the health and well-being of these individuals? So it's of huge concern. So from the charts, we know that obesity is common. In the United States, 36% approximately of adults are considered obese, a BMI of 30 or more. And in terms of youth, so not just the preschool, but youth in general, about 17% are considered obese. If we look at obesity and overweight, those numbers rise tremendously. So overweight is a BMI of 25 or greater, and 2/3 of our population in the United States is either overweight or obese. Huge numbers. So we know that obesity affects all sorts of different groups, but it affects different groups differentially. And this can be affected by ethnic diversity and by socioeconomic status and a host of other factors. So just looking at ethnic diversity, and this is fairly recent data. This came out in an article in Journal American Medical Association just this past year, a few months ago. And if you look at age-adjusted rates per ethnic group, non-Hispanic blacks have really the highest rate of obesity. Mexican American tend to be almost as high, about 40%. All Hispanic, 39%, and non-Hispanic white, lower, but still obviously concerning. So between 1/3 and half of the population is considered obese, with variation based on ethnic background. Socioeconomic status, it varies. So being low income can affect some ethnic groups more so than others. So it's not easy to make generalizations. But in general, the lower socioeconomic status tends to have higher rates of obesity. With education, tends to be with lower rates of higher education, you see greater obesity. So it really is a setting where health disparities exist based not only on access to care, because we know that is certainly a situation, but also with just prevalence rates of existence of obesity and then some of the associated conditions. And as we talk about some of the comorbidities, keep in mind that I'll talk in generalities, but the comorbidities also are differentially affected by ethnic diversity. The rates, for instance, of cardiovascular disease in the non-Hispanic Black African American group is different than in Mexican American or total Hispanic. So very much different. The costs, the economic costs of obesity are huge. Medical costs I'll get used to this yet. So in 2008, the medical costs are estimated to be $147 billion in the United States. And many of these comorbid conditions are among the primary causes of death in the United States. Cardiovascular disease, cancer, and so forth. And we know from various studies and statistics that though there's a multitude of causes for these chronic diseases, there is a pretty significant amount of that causality that can be attributed to nutrition and to lifestyle behaviors. So nutrition, physical activity, smoking, other choices, so to speak, and aspects that can be modified. So understanding the problem obesity, as we've sort of been talking about, I know you've been learning in classes, it's multifactorial. There certainly is a genetic component. We know that from looking at twin studies. There tends to be a fair amount of concordance in individuals who are twins. Even if they're raised in slightly different environments, they both tend to have similar weights. We also know that weights can track in families. If the parents of children are overweight or obese, the children are more likely to be overweight or obese than some of their peers. How to separate out whether that's genetics or environment, very difficult, because they both have a play in the outcome, definitely. But we know that our genes haven't really changed in the last 20, 30 years. We basically have the same genetic makeup as we did then. But the rates of overweight and obesity are definitely on the rise. They've been skyrocketing. They have leveled out a little bit, but they're still high. And so the change over the most recent part of our lifetime is not due to genetic drift. It's really due to changes in the environment, the obesogenic environment that we live in, the availability of foods, the change in physical activity levels, the convenience that we have of a lot of things in our lifestyle, and what we do in terms of our behavior in response to that environment, choices that we make. And it does, in terms of nutrition, come down to energy balance. If the energy input is greater than the energy output, then you shift the balance and weight is gained. So regardless of whether that's physical activity decreasing or calories in, the balance is shifting. We have a greater energy balance than output. And we know that portion sizes of food definitely increasing. If you go to a convenience food store today, the size of the portions that you get are different. If you go out to a restaurant, they're much greater. And people eat out more today than they did 20, 30, 50 years ago. We have a very fast-paced lifestyle, and some of these choices are influencing energy input. So a multifactorial problem. Because it's complex and multifactorial, it's also very complex to combat. So obesity really is defined as having an excess of adipose tissue or an excess of body fat, or sort of comparing that to body composition overall, having an excess of body fat, adipose, in relation to lean body mass. And we can assess overweight or obesity, or assess sort of the phenotypic expression of this energy excess, energy balance problem by just looking at the individual. Often you can look at someone and say, looks like they're overweight, but to have actual data that we can look at and compare, you can measure waist circumference. And there are objective measures that we apply. For men, high risk is considered greater than 102 centimeters or 88 inches, or rather 40 inches. And for women, 88 centimeters or 35 inches. So that gives a picture of central adiposity, or this where someone carries their weight. Another way to express that is measuring the waist circumference, but expressing it as a ratio to the hips. And so that is looking at a waist to hip ratio. High risk is considered greater than a ratio of 1. So that's further defining, is it just sort of a global carrying weight all over the body, or is it really centered solely around the waist as compared to the hips or the lower body? And then a further way to do that is to calculate the body mass index. And that is an equation that uses weight expressed in kilograms divided by height in meters squared. And this is a clinical index. The waist circumference or waist to hip ratio are also used clinically. So if you go to see a physician, they'll definitely take your body weight, ask you to step on a scale. They may or may not ask to measure around your waist or your hips. In field studies, doing community work, Certainly a scale is probably the most readily accessible, but waist circumference is also used, either in conjunction with the scale or instead of. And these are very good descriptive measures. So the BMI, there are charts available, and so it's readily compared to various charts. And the classification for underweight or normal weight or overweight or obesity are listed here. And the hope is that most people would fall within this range of 18.5 to 24.9 or almost 25. And that's what's considered normal, and that's in comparison to a variety of health indices, insurance actuarial tables, and this sort of thing. And so it's considered an optimal weight, if you will. And then overweight is the next category up, 25 to almost 30, and then different classifications of obesity. 30 above, 35 and above, and very, very high at 40 or above. And 40 or above is considered morbidly obese. And what we see is an increase in health risk in general as you go up in terms of this. It's actually sort of a J-shaped curve. There is increased health risk at the very low. Someone is underweight or malnourished or low body weight. There's some increased health risks, but they tend to go up dramatically as you get into the obesity range, and that's the basis of this classification. So we know that excess body weight or abnormal fat is actually a predictor of this health risk. But BMI doesn't address body fat distribution. You can have someone with a high BMI who is an athlete. Say, take a look at a football player. They have a high BMI. Does that automatically mean that they have a high health risk for chronic disease? Maybe not. You really need to know a little bit more about their body composition. And if you were to investigate their lean body mass versus their fat mass, they probably actually have a very low fat mass and a relatively high lean body mass because of the musculature. So it's important, if possible, to further investigate what is the body composition itself. And in community work, field studies don't really have the ability to do underwater weighing, various other types of things, but you can get a look at the body fat distribution. And so having something that tells you information about waist or waist to hip is very useful. And so we can categorize the distribution as this A category, the central or upper body, can sometimes be termed android, or you probably have heard the apple body distribution. And that really is the central adiposity, someone who carries their weight in their abdominal region. It can be characterized sort of as the beer belly, sort of a more crude way of talking about it. And it tends to be more common in males to carry their weight there, but you also see that in females too. The more traditional, stereotypical female distribution is this B category or lower body, gynoid or pear-shaped. And so the larger hips and thighs, in addition to some weight around the waist. But if you just sort of on an absolute basis compare the two, the same amount of total weight carried in different ways, this person with the pear-shaped distribution is probably at lesser risk or somewhat more protected than this apple or visceral body fat. And so the question has been asked over the years of why is that so? What is it about this body shape distribution that gives greater health risks to those individuals? It seems to be something more than just total fat and where it's located on the body. And we're finding out that there are some very interesting biologic differences of fat tissue, adipose cells, that are positioned in the visceral or subcutaneous area in the stomach as opposed to other places on the body. So if we step back and look a little bit about complications of obesity to get that backing, and then talk a little bit more about fat cell biology, we'll go down the pathway of finding out about that. So there's a whole host of different metabolic diseases that are associated with overweight or obesity. Just starting at the top and sort of working around clockwise in this diagram. Cardiovascular diseases in general are one of the huge risk areas, and stroke is one type of cardiovascular disease. So cardiovascular disease, or atherosclerosis, affects vessels throughout the body, and it can affect vessels in the brain as well as in the neck, throughout the heart area, the abdominal region, as well as the legs and peripheral. You also have effects of hypertension as well as dyslipidemia. So high blood lipids and high blood pressure affect coronary heart disease and cardiovascular disease in general, which includes stroke and can also include kidney disease as well. Cataracts seem to be a little bit higher in incidence in someone who's overweight and obese, but proportionately the risk for heart disease is much greater. Another area of huge risk is diabetes. So changes in blood glucose handling and homeostasis, the risk of diabetes is greater in someone who is overweight or obese. And the sequelae, the consequences of having diabetes, are also very great. Someone who has diabetes is also at higher risk of developing heart disease and of kidney disease. Pancreatitis is another potential risk of being obese. As someone is overweight and obese, their ability to handle glucose effectively can be sort of challenged, and the pancreas, the beta cells, are often challenged to put out more and more insulin. The diets may be high in fat, just the ability to have enzymes that are exocrine enzymes secreted by the pancreas to help digest the fat. All of these sort of challenge and stress that organ, and so it can be affected. Cancer is another area, a comorbid condition, but not all cancer across the boards. It really is specific to certain types of cancers, and it's differentially affected male and female. So female breast cancer, gynecologic cancers are increased with overweight and obesity, as well as in both male and female, the risk of colon cancer and pancreatic cancer and kidney cancer and prostate. Phlebitis or irritation of the blood vessels can be an issue. Gout can also be a problem in obesity. Difficulties with skin integrity, breaking down of the skin, ulcerations, particularly in somebody who has peripheral vascular disease. I mentioned some of the gynecologic abnormalities. It's not just gynecologic cancers, but there is a syndrome called polycystic ovary syndrome in women that is hormonal imbalance that affects their gynecologic function, as well as brings in difficulties that are similar to diabetes. So a variety of problems that can lead to infertility and abnormal menses. Gallbladder disease, again, sort of similar to pancreatic disease. As you stress the gallbladder with typically a high dietary fat intake, high cholesterol, can precipitate out and form gallstones, blocking some of the outlets in gallbladder disease. Another high risk is non-alcoholic fatty liver disease. You think of liver disease as being alcoholic liver disease, somebody that drinks a lot and has cirrhosis. Well, one of the most prevalent high-risk emerging aspects, complications of obesity and overweight, is fatty liver disease. The body just, adipocytes, the fat cells, are overloaded in their ability to store more fat, it becomes shuttled out and is stored in other tissues, the liver being one of those. And a large percentage of individuals who are overweight or obese have fat deposition in their liver, which over time can lead to endpoint of cirrhosis, just like alcoholic disease. Not quite in the same rate, but still, if you took a population of obese individuals, took a liver biopsy from them and measured it, looked at it histologically, there would be, at least in more than half the cases, high amounts of fat. Their liver enzymes are going up, so disease setting in. And then sleep, pulmonary disease, obstructive sleep apnea is a problem in obesity, and chronic obstructive pulmonary disease. So a whole host of potential problems. That's not to say that everybody who is overweight or obese gets any or all of these. There are some individuals that are actually quite healthy despite their higher weight. And so we can't make overall generalizations, but as a stereotype and to talk about today, there is definitely the predominance of individuals who are overweight or obese who have some of these comorbid conditions. And what we'll talk about really mainly is those that are the most prevalent: heart disease, diabetes, and the liver disease that is often associated with that. So mechanisms for what I'll be mentioning may differ, say for cancer or for some of the others. So this is my focus for today. So these obesity-related diseases are sometimes called co-morbidities, and this visceral adiposity is very strongly associated with them. Lack of physical activity certainly contributes, but it seems as though this visceral fat seems to trump physical activity in terms of causality. Risks of diabetes and heart disease are doubled or greater in those that are overweight. And we know that children who are obese or overweight are also at risk for developing these diseases. Used to be that we didn't see these adult diseases of heart disease and hypertension and atherosclerosis and diabetes and so forth too often in children directly related to obesity, but we are seeing those now. And so the question is, of these youth, we know that about a third of obese youth have some of these adult comorbidities. What does that portend for them in their future? Does it mean that they will have greater risk of chronic diseases later in life if nothing is done? Very likely. We're not entirely sure. This is an evolving problem. So we need to have an understanding of how these differ in children as opposed to adults. And we're still trying to learn all that we can about how the extent of pediatric disease related to obesity and overweight predicts adult disease. And so we need to find out a little bit more about the function of the adipose cell and how that's related to these biologic effects, and in particular to the visceral adiposity. So adipocytes, or fat cells, they're more than just a sack of fat. That's what we used to think. They're basically a large lipid droplet. This is a lipid stained red, and you can see the cell membrane, a little bit of cytoplasm and nucleus and so forth. It's mostly fat. However, we know now that the functions are more than just storing fat. Certainly lipid or triacylglycerol storage and mobilization is one of the key functions, but another key function is that of an endocrine function. We now understand that there's a lot of cytokines and adipokines, and so these are peptide hormones that are secreted by the fat cells that affect not only the cell, the fat cell and cells around it, but the cells throughout the body. These are sent out into the bloodstream and affect systemically the body's homeostasis, its level of inflammation. Many of these cytokines like TNF-alpha, interleukin-1 and 6, these can be pro-inflammatory cytokines. So not necessarily that they cause a raging infection like you might see if you get a cut and it turns red and pussy and so forth. Not that kind of infection, but the kind of infection that's really a subclinical inflammation throughout the body that affects vascular cells, that affects muscle, beta cells, all sorts of different tissues in the body. Further, some of these adipokines, adiponectin, leptin, and others, those have to do with energy balance. They can affect appetite regulation. They have effects on the brain cells and sometimes increase appetite, sometimes decrease appetite, depending on which adipokine you're talking about. And they are secreted in proportion to the fat cells of the body. So as adiposity changes, these levels of adipokines and cytokines change. And what we know is that the size and the location of these fat cells really matter. This visceral adipose seems to be slightly different than adipose, say, subcutaneously underneath your skin in your arms or your legs. The visceral adipose cells tend to be a bit more lipolytically active, so they function more rapidly in releasing triglycerides and free fatty acids. So you get more free fatty acids being released from these fat cells. The body doesn't just circulate free fatty acids, they're packaged into lipoproteins so that they can circulate in the aqueous blood. And so individuals with high visceral adiposity tend to have more circulating lipoproteins, so that means more LDL cholesterol and so forth. They also mean that your liver is more active in trying to deal with these lipoproteins, both producing them and taking them up and recirculating and so forth. So more lipolytically active. They also tend to secrete more cytokines because they associate within the visceral adipose tissue, tend to associate other immune cells with these fat cells. So macrophages, which can be inflammatory related cells, and the macrophages put out more cytokines, more pro-inflammatory cells. So they do matter in terms of size and location, and they play a role in the pathology of some of these obesity-related chronic diseases. And what we also are learning is that, as Dr. Stewart implied, there are many prenatal influences that can impact later life. And these influences, particularly epigenetics and glucose and so forth, can influence organ development. They can also potentially influence the development of adipocytes. So this is just a slide for adipocyte development. You don't need to know the details, but the take-home message is that adipocytes don't just automatically exist as adipocytes. They progress from mesenchymal cells into a pre-adipocyte into the final mature adipocyte. And they're affected by transcription factors, by a whole host of various things. And they can be affected by maternal and fetal environment, as well as environment during childhood and later in life. And we know that fat cells, adipocytes, can grow larger, they can hypertrophy, and it seems to be that in overweight and moderate obesity, most of what happens to the fat cells is that they just get bigger. But in very, very extreme overweight and obesity, BMI of 40, you tend to see hypertrophy as well as hyperplasia, or just more fat cells developing. That's not an absolute truism. You know, if you have a BMI of 29 versus 35, you only have X number of cells. No, we all have hypertrophy and hyperplasia of fat cells. But after a certain point, these fat cells just can't accumulate any more lipid, and so the body begins to make more and more fat cells. So that has implications for weight loss and weight maintenance of how many fat cells exist in an individual. So this is sort of a key slide that brings together some of what I was saying about the inflammation. So we know that we have adipocytes which exist in the body, various sites. When we have increased nutrient flux, here's a Big Mac or hamburger. It's really not just one hamburger, but it's the net effect, that overall total energy balance, that causes hypertrophy and hyperplasia of these fat cells. And they put out some cytokines and adipokines and so forth. As this occurs and increases more and more, these cytokines tend to recruit in macrophages. These macrophages are immune cells. They take up residence in between and along with these fat cells. And these macrophages put out more chemokines and cytokines and stimulate release of more free fatty acids. And so you have this activated set of fat cells. This visceral adiposity tends to be more activated in terms of a more activated fat pad depot than subcutaneous fat. And so as adiposity grows in the central area, it promotes sort of this cycle of increased metabolic activity, which promotes some of these different diseases. And the increase in the macrophages and the free fatty acids then can feed back and influence further development of adipocytes. So this just breaks down this set of activated adipocytes into factors that can affect metabolic control. These are some of the adipokines that can be released. These are inflammatory cytokines that can be released and proteins that are affecting things, and then tissue effects. And so what we have then is a setting that affects systemically the whole body. And so as you get an excess of lifestyle factors, whether it's sedentary lifestyle or energy-rich food, resulting in obesity, then you get activated macrophages. You can also get involvement perhaps of intrauterine environment that promotes things. If you have this thrifty hypothesis, what you see, as Dr. Stewart described, is early deprivation, small body weight, but later gain in life of excess body weight, adiposity, and cardiovascular disease and others. What the thought is that this programs, if you will, some of the effects on the fat cells and leads to what sometimes is called a sort of a lipid overflow, in that regardless of the beginning etiology, you have a metabolic situation where the body just can't store fat anymore in some of the adipose tissue. It affects other tissues. You get storage of lipid, as I mentioned, in the liver. You can also get some in the pancreas, affecting that function. You can actually get storage of lipids in the muscle and around the heart. And these then affect the ability of these tissues to handle glucose, to metabolize other compounds. You get an altered metabolic profile, and you get a greater predisposition to cardiovascular disease and diabetes, type 2 diabetes, and metabolic syndrome. Another way to look at that is not just what is stored in those tissues, but what happens functionally. And so you have endothelial cell dysfunction, so the vascular system has some changes. You get insulin resistance in the liver. You get insulin resistance in the muscle tissue and pancreatic beta cell dysfunction. And so you have type 2 diabetes, liver disease, and cardiovascular disease. So together, the contribution is pretty marked. So bringing it together in words as opposed to the pictures, this sort of lays out what I've been presenting about adipocyte dysfunction, adipokines. You get cellular stress, mitochondrial oxidation, endoplasmic reticulum stress, increasing inflammation and oxidation. You get problems with thrombosis, insulin resistance, so the effects of insulin are not as as effective in bringing down blood glucose, and then you get interactions in all of these different metabolic organs throughout the body. And so that then can lead to these issues with visceral fat, whole body metabolism, and cardiovascular disease. And metabolic syndrome really can be defined as a condition which is a constellation of different factors. Dr. Stewart referred to that as one of the sequelae that can be seen with some of these origins of developmental disease later in chronic life. And so it is a very heterogeneous disease, but regardless of exactly which factors come into play, its ultimate influence is causing greater risk of cardiovascular disease and diabetes. So we know that the current population is very overweight and obese, and looking at data from national health nutrition surveys such as NHANES, we know that using criteria for metabolic syndrome, there is a large percentage of our population that actually does have metabolic syndrome. So not everybody that's overweight or obese, but here we have a third of our population with metabolic syndrome. It's defined as 3 or more of some of these following 5 aspects: abdominal obesity, high triglycerides, those circulating lipids, low HDL, the good cholesterol, high blood pressure, and high blood glucose. So all of these different metabolic factors, it only takes 3 of those. What we usually see is somebody with abdominal obesity, often high blood pressure, and then either triglycerides or glucose. This is not just a United States problem. Here's the US, certainly highest. This is prevalence of metabolic syndrome. But you look at various other countries, and let's see, France is relatively low, Iran is relatively high, Turkey. You see it in a wide spectrum of countries as well as ethnic groups. Risk factors, heredity is certainly one thing. We know that there are familial influences, genetic predisposition to diabetes and cardiovascular disease, and environmental influences certainly come into play and affect heredity. Ethnic differences, examples of the Pima Indians that are very, very susceptible, a Native American population, to obesity and diabetes. But there's certainly also lifestyle behaviors. TV watching habits for children puts them at risk for overweight and obesity. Low physical activity and dietary intake, positive influences can help protect against it, but diets that are high in fast food, high fat, high sodium, high sugar, and so forth certainly don't help the case at all. So the treatment, lifestyle changes, emphasis on weight reduction, emphasis on physical activity, both of which you're hearing a lot about in the course that you're taking this quarter. And certainly we also need emphasis on the environmental factors, and so changes at every level of this ecologic model, from individual to the family unit, to looking at what sort of interventions can be put in place in the schools. You'll hear some about that tomorrow from one of our speakers. And certainly community-wide and at national policy level, there need to be influences, positive influences. There's many attempts at this, but they're not always successful enough, as we see from the population rates of overweight and obesity. There's also medical interventions that can be put in place, drug interventions such as statin drugs that lower cholesterol, antihypertension drugs, and these are also critically important if people have the existing comorbid conditions of hypertension and so forth. But as in many other things, prevention is so much more effective than treatment once you have the condition. So really, I think the most important conversation needs to be at what can we do on a public health level to combat these rises in obesity and overweight and the resulting comorbid conditions. And so I think it's important to recognize what the biology is behind the development of these conditions. It's not all just about physical activity and good food versus bad food. It really has a lot to do with the metabolism and how we can intervene or prevent some of these deleterious effects in terms of metabolic changes. And so rather than summarizing with lots of words, which I've already given you words and pictures, I put together this word cloud just focusing on a text that was talking about metabolic syndrome and some of the biologic etiology. So I think just from looking at this, you can maybe remind yourself of some of the predisposing factors, the metabolic changes, and the biology behind metabolic syndrome. Which focuses a lot on some of these pro-inflammatory changes, visceral adiposity, white adipose tissue, obesity, hyperglycemia, diabetes, macrophages, steatosis in the liver, obesity-linked, a lot of signaling, metabolic constellation, type 2 diabetes, hyperinsulinemia, all of these factors which are really chronic metabolic changes, and how can we target interventions to approach this problem. So thank you very much.